This episode is sponsored by PACS, the gold standard in emergency response bags. So when you're working under pressure, you need kit to be both dependable, tough and intuitive, and that's exactly what you get with PACS. Every bag is handcrafted by expert tailors who understand the demands of pre-hospital care, from the high-tech, skin-friendly and environmentally responsible materials to the cutting-edge welding process that reduces seams and makes cleaning easier. PACS absolutely puts performance first. They've partnered with 3M to make perfect reflective surfaces for better visibility, and bright grey interior makes finding kit effortless and fast even in low light. With over 200 designs, PACS bags are made to suit your role, your needs and your environment. And thanks to their modular system, many bags work seamlessly together no matter the setup. PACS doesn't chase trends, their designs stay consistent, so once you know one, you know them all. And if your bag ever takes a beating, their in-house repair team will bring it back to life. PACS are built to perform, made to last. Learn more at pacs.bags.com or head to the show notes for further details. Before we get started on today's episode, a quick introduction to VitalStream. VitalStream is a wireless, wearable, non-invasive hemodynamic monitoring platform designed to give continuous real-time physiological data, so you're not relying purely on intermittent cough readings when patients are unstable, moving, or in a non-traditional care space. So it uses AI algorithms and patented pulse decomposition analysis to continuously measure blood pressure and advanced hemodynamic parameters such as cardiac output, stroke volume, systemic vascular resistance and fluid status, helping teams understand whether a patient is fluid responsive and what's driving the physiology. BHA Medical's VitalStream solution focuses really on getting that continuous non-invasive monitoring into acute care workflows, streaming real-time data to centralized platforms so clinicians can make earlier, better informed decisions. And for corridor medicine, where patients can end up in areas without usual monitoring infrastructure, the key issue here is misdeterioration between spot checks. So continuous trending is the point, reduce blind spots, supporting early recognition of hemodynamic decline, helping teams prioritize interventions when staffing and space are stretched. And for pre-hospital care, where we're interested in keeping the physiological story visible from first patient contact through transport, VitalStream is designed for rapid application, fit and calibrated and monitoring within 90 seconds with a low pressure finger sensor, so crews can follow trends in real time rather than snapshots. For more information, please head to the show notes or go to bha/medical.com and look at the VitalStream option there on the platform.
You're listening to the Pre-Hospital Care podcast on the Medics Academy Network.
Welcome back to the podcast. Today we're looking at airway management. Airway management remains one of the most critical and technically demanding aspects of pre-hospital care. So in this Pre-Hospital Airway Compilation, we bring together leading voices in airway management to explore the fundamentals and also look at some of the controversies and high-stakes realities of managing the airway outside of the hospital. So across these conversations, we move from airway assessment to respiratory evaluation, and then we look at advanced interventions such as rapid sequence induction, suction-assisted laryngoscopy, and airway decontamination or SALAD. We also look at front of neck access or FONA, and then we look at the challenges really that are unique to the pre-hospital environment, that of unfasted patients, some of the low light conditions, and indeed challenging dynamic environments that we're dealing with in pre-hospital care. We look at also some of the practical approaches to decision making under pressure and explore where we can come into the stepwise airway management strategy, from optimisation and monitoring all the way through invasive surgical techniques. So first up is John Chatterjee. John is a consultant anaesthetist with an interest in pre-hospital care, difficult airway management, thoracic anaesthesia, and also high-risk anaesthesia. He's worked and taught internationally across the world, and he currently and has worked in London's Air Ambulance for an extended period of time as a consultant flight physician. Alongside John, we're joined in this conversation by Cliff Reed. Cliff is a retrieval physician with more than 2 decades of experience across air ambulance and critical care services. He is an internationally well-known speaker. He works at Sydney HEMS and he teaches around advanced airway management and the development of the techniques such as SALAD, helping clinicians improve performance in some of the most challenging airway scenarios imaginable. So in this compilation, we explore a wide variety of knowledge domains, that of the challenges, the airway assessment, declaring and communicating findings of a structured airway plan, understanding respiratory effort and recognizing when intervention is and isn't required, stepwise airway management and identifying escalation points. We look at VL versus DL. We also look at cases that have shaped the guest practice and some of the key lessons that they've taken away from their experience. So this episode really aims to provide a structured and practical approach to pre-hospital airway management, and indeed one of the most challenging and consequential interventions we practice outside of hospital. I do hope you enjoy.
If you look at the life of a fighter jet pilot, they spend time training to once in every 1,000 sorties or less actually going on a live mission. And what they're going on is something with limited information, having to react to what they're doing. And that is exactly what the pre-hospital airway is like. We need to train for this. But the difficulty is when you finally get there, you don't know exactly what you can expect. You've never met this patient before, and you don't know their history, and you don't know the team you're working with, and you don't know the full history of why they've been injured and everything else. And, one of my colleagues, when I was talking about this in hospital, said, and pre-hospital, you don't have pillows. And we have pillows in hospital. I work mainly with the London Ambulance Service now. Pillows are an absolute premium. But all these things mean that actually when you're doing a pre-hospital anaesthetic, you're doing something much, much more challenging, and not because of the holes that you're putting the tubes into, but because of the entire environment around you that just makes it harder. You can kind of divide these up into the patient things, the environmental things, and the human factor things. The human factors, I think, is the biggest challenge, and I guess we'll get onto that a bit later on about some of the cases and stuff that I've been involved in. In terms of the environment, you want to try and make it as normal as possible. And the way in my HEM service in London, where we work very closely as a 2-person team, I sort of emphasize on the paramedics. What your job is to do as the expert in the pre-hospital environment is to try and make it as most like a hospital as possible for your doctor, because they're going to be least experienced there, and you want to bring all those things in that make it as easy as possible. So getting the bed to the right height, getting things positioned, getting a standardized kit up, so everything, you start to bring some order into the chaos, and lighting and all these other things sort of help to make that environment better. But there are things you just can't control, but you can ask for sound to be reduced and all that. And if you think about that kind of thing when you play into the human factors of asking you to do something relatively simple when you're not tired and you're not under stress versus doing the same thing when you are tired and under stress, it's that same thing of all these distractions make it harder. Just like I can walk through the door of my flat every day without any problems, and I can leave the flat every day without any problems. But for example, this morning, I walked out and I forgot my keys because I was tired. I was stressed from other things going on. I didn't want to go to the things I had to do today. And all these things, they just distract you. And things that you would never think of distract you. And that's the environment there. In terms of the patients, they're rubbish. The patients just don't play ball. In hospital, if my patient's terrible and a heap of a patient, what I do is I find the best possible excuse to punt them onto another day or get one of my colleagues to do them. You just can't do that because you're pre-hospitally. And you will end up with the difficult airway, obese, vomiting patient in the worst condition. And it's just, you don't have the option of delaying, calling help, and you are that one thing there. And where I think the role of the 2-person team is really critical here is supporting each other in trying to make that patient and look forward to those things. And so what I say to the paramedics who often work as the assistants in the London system is you're sitting a few degrees off from the patient. You've got a much better side view of that patient. Look at them. Look at what a patient should look like on a trolley in an anaesthetic room in an ideal intubating condition. Yes, the environment, if they've got a traumatic injury, you might have to put them, in inline stabilization. You might not be able to. But even in inline stabilization, you don't want the neck, back at 30 degrees negative. You want it at a neutral position, so you can do things to mitigate that. You don't want someone who's positioned so poorly that their sternum is as far up as their chin. You want to have that kind of angulation, and these things you can teach people to look at specific points and specific angles and stuff. But the human eye, the Mark 1 eyeball, is brilliant at just saying that looks right, that doesn't look right. And so you could almost just do flashcards to teach people, like, this is what a patient should look like from the side. This is not what someone should look like from the side. And simple things like that. And then when it comes to the CRM, we put people through the ringer in the courses, in the helicopter crew courses before they start with us, and obviously on the job as well. And I remember seeing a beautiful piece of critical or crisis resource management when we gave a normal mannequin to a pair of practitioners, a senior hospital doctor and a senior paramedic, who were both very experienced, and you put their peers around them watching them do this moulage. The senior doctor went in and said, I can't see anything. And in his mind, he's thinking it's a trick. This is a difficult airway. And it's not. It's a completely normal mannequin. And his co-practitioner, the paramedic, puts his arm on his shoulder and goes, it's all right. Just take your time. Tell me what you see. Tell me what we can do to improve it and try these tricks. And then when he got the view, the paramedic who had sort of gotten through this stress then tries to put the circuit together, and literally you see a filter, a catheter mount, a CO2 line all just fly up in the air in sort of in unison. It's just like a beautiful shower, but then you just see this guy's face look absolutely crestfallen that he screwed this up. And at this point, the doctor goes, it's okay, just get the filter line, get the catheter mount, get this, put them together. It's no problem. The SATs are okay. And this sort of yin and yang of reassuring one another of the different parts of the procedure, that's what makes it really work. But equally, those are the points where it can really fall apart. So I think the team is absolutely critical to this. If the wider team is not on board, it makes it much harder. So as a practitioner, I have my level of skill, my level of experience. If I'm working with a London HEMS team, I have one threshold for when I would elect to intubate and give an anaesthetic. If I, as a same practitioner, am working in basics, so this is working out of my own car by myself, or I say by myself, as a team of one, but joining the ambulance service there, I don't come with a buddy that I've trained with that I know. My threshold for anaesthesia goes up massively. And this is where the team really makes a difference. So what I say is when I'm working by myself, I take the checklist out and I go to, and speak to who's going to assist me. If I decide that we're going to do this, and then say, right, this is what we're going to do. I'm going to brief you and we're going to brief the whole team. We're going to do this in slow time. And so if there's a time pressure that means I can't do this, then this is not the anaesthetic I should be giving pre-hospital. We should just be going to somewhere, because for me, it's not about who puts the tube in. It's about when that patient gets the oxygenation and the ventilation that they need. If it's going to be faster, me just getting them somewhere else and swallowing my pride and saying, you're better doing this in a district general hospital than me doing it outside on the road, that's the right thing for the patient. And that's what you've got to keep an eye on. Because I know if I'm going to do it as a basics doctor, I need to take time to brief everybody and do everything. Whereas I know if I'm doing it as a HEMS practitioner, I've got the team around me, and that makes all of the difference. And so in terms of bringing that team on board, you need to have people believing in your decision. And this is where I think when we talk about airway management, we talk about stepwise processes, and we talk about doing things in A leading to B, leading to plan C, etc. But actually, I think the decision process, you could almost look at it backwards. If your patient does need an anaesthetic and they need to have their airway managed pre-hospitally, then you've already decided at that point that that patient is going to get a surgical airway if they need it. The point to decide whether they need a surgical airway is not at your third attempt of laryngoscopy and failure, because that's just all the wrong thing. You need to front load your thinking and say, does this patient need it? Can this patient do well getting to hospital without us doing these things here? If the answer to that is yes, then I shouldn't be mucking around. I've got my entire life to play with drugs and tubes and things and do things, and plenty of opportunities will come up to do stuff. And I don't need to do that now. I need to do what's right for that patient. And so that decision-making is key. And so, again, what I say to our doctors and paramedics in London is look at the SOP, the standard operating procedure. There are 5 or 6 really simple indications. If you and the paramedic cannot agree a simple indication, then you should be phoning somebody else for help and thinking about it. Yeah. And that means that all your decisions are made for you then, where you proceed to. And that, by bringing the team on board, saying, look, guys, we're doing it because this patient's got respiratory failure. I think we need to ventilate them because of the physiology of the lungs, ABC, and saying all these things. And then they're on board with you. And then they want you to win. When we talk about video laryngoscopy, it's really interesting. So in my last 25 years or so through medicine, there've only been 2 big changes in anaesthesia. Don't tell any of my colleagues that write papers on minor things about that, because obviously they will think the biggest thing is changing from 18.5 to 19 mils of propofol. But actually, there are only 2 really big things. And so the one big thing is moving away from tubing every patient to using supraglottic devices. And that's Archie Brain developing the laryngeal mask airway in Reading and the Royal London. That's revolutionised and changed what we've done. That change came in coupled with the use of a drug called propofol, which again changed hospital anaesthesia. The other change is video laryngoscopy. And I think this is one of those things that is akin to when I started at London HEMS, I was instructed and learned how to read a map book and navigate from a map book with this new funky device called a sat-nav in the background. And the idea that we would throw the map book away, or at least, relegate it to the back seat was unthinkable. That you can't do that. You can't rely on this sat-nav. What if this happens? What if that happens? And all these mitigations. And so you sit there and you go, that makes perfect sense then. But you look back at it 20 years later and you go to a new ambulance person, a new doctor, do you, get the A to Z out and nav to Oxford Circus? And like, go away. You're a muppet. Just use sat-nav. Use Waze. I mean, my other half gets very frustrated with me when I go, I know the road. She goes, I don't care what you know. I want to know what Waze knows because I want to get there faster, because the technology is better and the technology has moved on. It's, and I think that's where we are with VL. Right now, VL is the sat-nav for the person with the map book. And we in the UK are kind of like, not sure about this. But you look at other countries where it's been in more frequently and for what feels like longer, though obviously the technologies progress the same around the world. And you find that actually it is replacing it. So you speak to North American practitioners and some of them will say, I haven't used a direct laryngoscope for years. Now, you have this argument of this changeover process of should we still be able to use a map book? Should we still be able to use direct laryngoscopy? There's absolutely a good reason for that, because VLs are fundamentally different to direct laryngoscopy. And you need to understand what it adds and what it takes away. So in the same way that using a sat-nav adds to your efficiency and route planning, it takes away your general knowledge of where you are and the options should it fail. In the same way, direct laryngoscopy is a particular process and a particular skill set of how you use the blade and how you get your view. There are video laryngoscopes that progress along that, and we've chosen one at London that uses same geometry of blade and the same technique, which means there's a progression in your technique. And we were talking about this before we started recording. We used to carry a device called the Air Track, which is a very good device. It's not that the device is bad, but the idea that when things start going wrong, I'm going to ask you to do something completely different. So things aren't going right. Pat your head, rub your tummy, and stand on one leg, and then do something different. It's not going to work, and that's why I think when we're talking about the fighter jet scenario, you want to train people in a way and use devices that give them a continuum of skill. And that's where video laryngoscopes come in. And so if you have a normal geometry, what we call a Mach geometry blade, that's the same technique, that's the same view. You can then hyperangulate that blade, which changes the technique slightly, but it's still a continuum. You then have devices that are totally hyperangulated, which are quite away from that starting point, but still on that continuum. And then you've got channeled blades, which are another thing in themselves. In the channel blades, a lot of people have reassurance because they feel that you've got something to guide it in rather than using a stylet or a flexible bougie. And they do have utility, but actually they mean that you need to be lined up with the crosshairs directly to go in. And actually, most anaesthetists prefer the unguided things, and they have a higher success rate with most of those, which is why you see a lot of channel devices slowly falling off the other end as this develops. But this means that as you go along, we not only do we need to remember some of the things from the map book, but we need to get faster at using and deploying the sat-nav. It's not like me putting my glasses on and going, right, Uxbridge Road and typing it in. You've got the kids that just said tip, tap, tap, and it's in. And of course I know where it is. It's just opposite that Nando's, and it's done. And that's where we're moving with this. But we are in that transition phase. So I was really lucky at World Extreme Medicine to meet Martin Bromley. He's a line training captain with a major airline whose wife passed away as a result of an anaesthetic disaster where people lost that signal. And we were chatting about these sort of things. And one thing he said to me is that what they train their captains to do and their leaders to do is the opposite of what we train people to do in the NHS and hospital. So in hospital, we talk about speaking up, and you have these speaking up guardians and these things saying you should champion your patient, you should speak up and say all these things, which is great. But what they teach their captains to do is listen up. And what I find is, when you look at these situations, there's usually somebody that has an idea that you should try something different, or this isn't working, or somebody even that actually has a solution but can help you offload. And actually, exactly as you say, when this is going wrong, first thing I admit, I had a difficulty last week, not a major problem, but it's just not working. And so I just said to the anaesthetic nurse with me, so I think I'm screwing this up. I don't think this is going right. What I'm going to do is I'm going to come out, I'm going to go back that step and just oxygenate the patient. Could you pop out your head outside the door and ask someone to get me some help? And one of my colleagues came and they just ran through the same process as me, and we agreed that this is not actually me just being a terrible practitioner, but actually we go on to a different step. And that just helps you, that speaking up and saying that this isn't right, I think it really helps. And the other thing I was going to say is, when I try and do these things, there are these halo procedures, these high acuity, low occurrence procedures. Most of us will never do a surgical airway, or if we do, we'll only do a handful. Most of us will never do a thoracotomy or these sort of procedures. And when I think about these things, this is very difficult to enforce training on people. But when you do the training by yourself, so not an organizational point of view, when I think about it by myself, I'll sit there, and some of the lessons I took from being able to talk to and work with some high performance athletes is they are exposing themselves to one incredibly high stress moment, might only be 15 seconds long in a 100-meter race, where everything banks onto this. And that's a halo procedure. That's a surgical airway. That's this thing where everything banks onto this. You've got to get everything right just that one time. And so for those, you sit there and they visualize the whole race. They visualize what they're going to do. So I visualize, what would I do if I need to do a surgical airway? What would I do if I need to do a thoracotomy, etc.? All these things. And then you sit there and you go, where would I put the knife? Where would I stand? What would I do? And that means that on the day that you end up doing it, 20% of your bandwidth is doing the job. 80% of your bandwidth is coping with all the other random stuff that's happening that you can't imagine beforehand, which seems to work much nicer. But it's really hard.
Oh, no, absolutely, absolutely, and you're right. It's very much this learned practice over time, and an observed practice in yourself and other people. But listening up is a fantastic sort of notion, and I know I'll take that away certainly into my practice. John, just looking at the way you maybe observe and monitor respiratory rate, or indeed how you assess respiratory rate. Are there any? So I learned quite early on in my practice that respiratory rate, certainly in the trauma patient, but also in the medical patient, is probably one of the most sensitive markers. It can be masked, but just being really attentive and sensitive to a patient's respiratory rate can be a really sensitive marker as to level of injury, decompensation, and or compensation. Could I get you to speak to how you assess it, and indeed what decisions you might make from it?
So I think when we talk about respiratory rate, the gains going with the aviation analogy is a thing called fixation error, where you see one thing at one point and then you run with that. And so you see a heart rate on a monitor of 80, I'm happy with that. And you don't see back that it's crept up slowly to 120 and stuff. And same with respiratory rate. But respiratory rate is much, much harder to do. And it's a very subtle, but as you say, an incredibly sensitive sign of what's going on with the patient. It's not very specific because it doesn't tell you that it's definitely a respiratory issue or a anxiety or pain issue or a hemorrhage issue. But it points you to something's going wrong. And I think one of the good things about respiratory rate is if you observe it, you're actually observing the whole patient. And so that's the other unintended benefit of looking at respiratory rate. I remember when I was doing intensive care medicine as a registrar, one of the consultants pulling me back and saying, step away from the patient, stand at the end of the bed, just shut up and look. And that's a really good way of observing respiratory rate. Just taking a moment, give yourself 20, 30 seconds, look at the respiratory rate. And as you're looking at the respiratory rate and counting it and looking at the chest, you'll see, are both sides of the chest rising equally? Is the patient actually pale? Are they well perfused? Do they look cold? And you start taking this whole stuff in. And remember that Mark 1 eyeball is a darn sight better than 1,000 monitors. Monitors are great for recording and giving you points and helping you avoid that fixation error. But taking that 20 seconds to stand at the edge of the bed or at the side of the bed and just look at the overall thing, is this patient okay? And this is something I learned from the great Gareth Davies when I was signing off and stuff. Like, when he was on shift with me and I was a panicking registrar going, I've got to get everything right, I've got to get every box filled in. He would look through the crack of the door of the ambulance and just look for 10 or 20 seconds, look at the patient, and he would either be reassured that it's fine, even John can't kill this patient, or he'd be like, John, you need to do something, and that's that thing. I think that's where respiratory rate really comes in. But the tricks of it is take your time, look at it, and then it's all about layering up and building your information and going through this cycle of take the information, make a diagnosis. Does it fit? Look at the information again. Is that building up towards that diagnosis and supporting you? Or is it, no, I've got this completely wrong. You start back at the start and you go. But the more time you spend with the patient, the more information you get. So I think the research driving practices is critical. And as a good example, this idea of us intubating patients pre-hospital that didn't have anything on their scans immediately afterwards was, very much frowned upon. You felt uncomfortable because your colleagues were going, why are you doing this? And the impact brain apnea stuff showing that actually this is a consequence of an impact that doesn't give you a structural brain problem, but actually, effectively scrambles your physiology for a short or longer period of time, depending on the impact, and the importance of early airway management. And again, we go back to the zero responder and the first person on scene, doing this airway management and listening to them and listening to their experiences and not discounting it because you've got someone with a patent airway now, but listening to the person say they weren't breathing, they were gurgling, they did have this really weird respiratory pattern. actually listening to that. And this isn't new stuff. This is stuff that comes from 30, 40, 50 years ago that we've forgotten and now we've relearned. This is really important. And this research, not only is it really important in terms of the airway management we do now, but I think it's really important for us to learn to listen to people and listen to the accounts and say, that doesn't fit with my current picture. So rather than discounting it, change my current picture.
John, that's fantastic. Absolutely fantastic. So if we could just migrate on to sort of seminal cases, or indeed a seminal case that you could speak to, that you've sort of learned a lot maybe about your own practice, or indeed about, just some of the fundamentals of airway management from your own practice.
So when I think about sort of seminal cases for me and airway management, they've not always been the ones where things have gone wrong. Because I think most people sit there and go, oh yeah, that one, this went wrong, that went wrong. But often when you have that, you sit there and you go, oh, do you know what? The answers were here, and this is what I should have done. Actually, for me, some of the cases that have really informed how I do things are about decision making. And so I think of, some cases where some of these are mine, some of these are my colleagues, and I won't go into too much because I don't want it to be identifiable, but cases where, people have made an early decision that's bad. They've gotten poor information, they've made a poor decision, and then they've stuck with it. And when you look at that case peel out, the outcome is fine. But actually, the road that they've reached to, the reason that you feel so uncomfortable, the reason that it's seminal, is because it just goes to show that the early decision making and loading your effort into that first few minutes to get the information, start your decision-making process correctly is so critical. And then also in the medium term of that patient, not being able to revisit your decision, say, do you know what, that's wrong. And I think of an impact brain apnea patient that I treated, where I went there and I thought, I've got this. I've read all the impact brain apnea stuff. This guy's fine. He'll just wake up. He'll be all right. And he wasn't. He died. And it's that feeling of those cases that start running away from you. And it feels awful. But you sit there and when you reflect on it after, you go, what went wrong? And what went wrong for me there, again, was decision making. I made my early decision and I stuck with it, and I shouldn't have. I should have reassessed. By the time I was reassessing, I was scrabbling. I didn't have that point of safety to go back to. The patient was just getting worse and worse and worse. And what in fact happened to this patient is they had an impact brain apnea, they had a sympathetic surge, and they had a heart attack. And what I was doing was I was treating someone along trauma lines. And in retrospect, it's plain as day. This guy was having a massive heart attack. And I gave him completely the wrong stuff. And by pointing that wrong direction, the hospital continued in the wrong direction for the last few minutes of this poor man's life. And you sit there and go, why did this go wrong? And all it comes back to is the decision making. And that's when it comes to airway management, it's not like the funky surgery stuff that Mr. Perkins and colleagues do in theatre. It's not the super clever pharmacology stuff. There is physiology. We can talk about respiratory physiology till the cows come home. But actually, it's decision making.
You go through the front of the neck when you don't have an opportunity to go through the other two orifices. If you can't go through a natural orifice like the nostrils or the mouth, then you go through the neck. There's 3 routes into the airway, and it's just one of those 3 routes. Now, nasotracheal intubation isn't usually done. It's quite hard, but we can certainly use adjuncts through the nose to help keep a patent airway. But if we're in a can't oxygenate situation, and we've exhausted those possibilities, then that would be one indication for making our own hole in the front of the neck. Another much rarer one, I guess, is if you've got a trapped patient and you literally can't get to the face to instrument the airway, you've only got access to the neck, then that might be an indication for a primary surgical airway or primary front of neck access. But yeah, just to keep it simple, if I can't oxygenate a patient through other means, then I make a hole in the neck.
Yeah, which makes sense, absolutely. And it is quite a rare procedure, actually. I mean, I've only done 2 in my career, but uh, maybe could you talk us through the potential risks and complications with pre-hospital FONA?
Sure, it sounds cheesy, but the biggest risk is not doing the procedure. It's failing to make an airway when you had an opportunity to do so. Of course, it's a surgical procedure generally, so there are risks with any surgical procedure. You can cause bleeding, there can be infection downstream, you can damage airway structures, you can damage vascular structures, you can damage nervous structures. But if you stick to the midline and you stick to a simple procedure that's honed, you're probably not going to cause any permanent damage that an ENT surgeon can't repair. So while it's prudent to consider complications of any procedure, you're not really going to do a front of neck access procedure unless the patient's in a life-threatening situation if you don't do it. So those risks of benefits versus harms are so in favor of benefits. It's such a tiny consideration. If you stick to the procedure, it's not really something that should be a reason not to do it. The caveat there is in infants and small children. If you're going to do front of neck surgical access there, and there are circumstances where that's indicated, the procedure is fiddlier and you do have a greater risk of causing significant injuries to the adjacent vascular structures. But again, there's a system you can train in procedurally that will minimize those risks.
No, indeed, absolutely, absolutely. And let's just look at how to mitigate some of those risks. Could you maybe speak us through the salad technique, Cliff, and indeed how that does offset or indeed mitigate some of the risks?
Yeah, sure. So just for the listeners who might not be familiar with it, SALAD stands for suction assisted laryngoscopy with airway decontamination. So this is a means of doing laryngoscopy through the oral route to do orotracheal intubation when you have a heavily contaminated airway. It might be vomit, it might be blood. And the procedure and the name were both invented by my friend James Ducanto, Jim, who's an anesthesiologist in the US, but he's also a serious resuscitationist, inventor, engineer, all-round amazing guy. And I've had the privilege to have some training from him some years ago and refreshed that recently with him this year. And the way Jim recommends you do it is you have a proper suction catheter in your right hand and the laryngoscope in your left hand. And you're anticipating a contaminated airway. And the key thing, and this is really important with video laryngoscopy, is that you don't allow your lens to get contaminated. So the suction catheter has to stay ahead of the laryngoscope camera, which is usually at the tip of the blade. And so the suction catheter goes in first. You might open the airway with your left hand, then you hold the suction catheter similar to the way you're holding a laryngoscope handle. So the curve of the catheter is the same as the laryngoscope curve. It's going to go around the tongue. But you can actually use that catheter to push the tongue down, almost like a laryngoscopy technique. You're making more space in there. You're pushing the tongue forward into the submandibular space, and you're actively suctioning the whole time with this right hand. You can then follow that with the laryngoscope in your left hand, and they use the term high and dry. Keep the laryngoscope blade high, so further out than the suction catheter tip, which keeps it dry, so your view remains pristine. It doesn't affect the video. And what you do is that you feed the suction catheter further down. This applies to contaminant coming up from the esophagus. And so you put it in the hypopharynx, the area just at the entrance to the esophagus, and you park your catheter tip there. And then there's a maneuver where the suction catheter is in your right hand, but keeping the tip where it is, you move the handle around and under the laryngoscope blade and into your left hand, so into the hand that's also holding the laryngoscope handle, and you pin that suction catheter between your palm on the little finger side, so your hypothenar eminence, and the laryngoscope. So you've coming from left to right, you've got your left hand, then you've got the suction catheter, then you've got the laryngoscope, and that suction catheter is pinned between your hand and the laryngoscope. So now you're holding two instruments with one hand, or two devices with one hand. You've got the suction catheter in your left hand, which is sitting in the place where it's going to suck up all that stuff coming up from the stomach, and you've got the laryngoscope. So now you have a clear view. Any ongoing regurgitation is going to come up your suction catheter, and you've got a free right hand for your bougie or your tube with a stylet in it, or even a second suction catheter to clear out any remaining contaminant before you intubate. And this is really tried and tested technique. It's very simple to learn. And what I love about Jim is, rather than just make up a technique and get people to train it on a sterile mannequin or a dead animal, is, you know, he's invented a number of salad trainers, so mannequins that will actually actively vomit and will pump up that mucky stuff, and it will just keep coming. So thanks to him, and with the help of a German emergency medicine colleague called Luca Unlu, we made a number of salad trainers in our own department here in Sydney, adult, child, and infant. The infant one's interesting because we go to quite a few pediatric drownings, sadly, and we have a number of recorded video laryngoscopies of significant pulmonary edema coming up via these infant airways. So our infant salad mannequin doesn't vomit, it has pulmonary edema, pink frothy stuff coming up from the trachea, which is a bit of a challenge because you have to modify your salad technique. You can't park it in the hypopharynx because it's not coming from there, it's coming from the airway. So that's a very challenging intubating mannequin. Complexity is the enemy of execution. So it's got to be simple from a human factors point of view. There's going to be a lot going on scene. There's going to be a lot going on in our brains. And the patient's going to be really sick often, and we're not going to have a lot of time. So there are various proprietary devices out there, but the system that I'm working recommends just using simple, available kit that we're all familiar with. So a scalpel blade, a bougie, a tube, maybe some gauze to control bleeding, and then all the things you need to have when you intubate someone, like a syringe to inflate the cuff and your self-inflating bag, circuit, and capnograph. But for us, we use a scalpel finger bougie technique. And you really want your kit packaged in a way where it's easy to check. So if it's in a transparent container, bag, pouch, whatever, then you can eyeball that kit at the beginning of your shift. You know it's all there. It can be tagged. And it's easy to retrieve when you're under pressure if it's kept in a standard place. And if you use an airway checklist, then you can make sure that checklist prior to intubation or prior to anesthesia includes that you've seen where your cricothyroidotomy or FONA kit is, and in some cases you've even got it out ready. You may have even marked the neck.
No, indeed, absolutely. So it's clear and visible, but like you said, there's an absolute reduction of kit there, so it's nice and simple. Yeah, Cliff, could you speak to the wider considerations? These are halo skills, yeah, high acuity, low occurrence skills. They do occur infrequently.
As you say, it's a halo procedure, so the opportunity to see one, do one, teach one, or do it for real under supervision just isn't going to be there. So your first one you ever see is often the first one you ever do. So we have to be 100% prepared for that. That means we need to be familiar with the equipment, familiar with the procedure, how to do it, but really, really familiar and confident with the indications for the procedure, so that when those indications arise, there is no decision. We've already made the decision in the past. This works really great with teams. So in our HEMS unit, we have a physician and a critical care paramedic. And so they would confirm indications together and proceed to surgical airway or proceed to FONA. And no one's having to have a discussion or a decision. You just confirm as a team the indications are present, and that's your trigger to go. And then you want to make sure that your head's in the right place. You cut out the noise and you get yourself in the zone, and everyone's got their own way of doing that. But the nice psychological tools for dealing with stress or emotional pressure that are recommended from Mike Loria and his crew include the breathe, talk, see process. So slowing down your breathing, square breathing, combat breathing, whatever you want to call it, just slowing down your breathing, which will control the rest of your autonomic hyperarousal. Talk is your positive self-talk. So if you do have any self-doubt or you are hesitating, just to yourself, silently, in your mind, you tell yourself, I've got this. We can do this. We're trained. It's indicated. It's go time. And then C is visualization. This is the successful completion of the procedure in your mind's eye, visualizing a successful outcome. No, expecting what it's going to feel like and look like if it goes right. And again, it's better if all this stuff is done in the past so that you're ready at the time. And then once your head's in the right space, your kit's out, the team's good to go, we would make sure we position our patient with the neck extended. So we'd remove any pillows or occipital support that we had in place for intubation. Confirm landmarks, do a laryngeal handshake, grab hold of that cartilage, and with one finger feel the cricothyroid membrane, and then with the other hand we do a stab and rock incision if the membrane's palpable horizontally. Finger goes in. So a stab and rock incision horizontally if we can palpate those landmarks. We then put a finger in the hole and we confirm out loud, I can feel tracheal rings with my finger. We then pass a bougie alongside it. I can feel a bougie. So if you can feel tracheal rings and you can feel a bougie, your finger is definitely in the airway. So the finger can come out because the bougie is definitely in the airway. And then the tube goes over the bougie, the cuff's inflated, end tidal CO2 is connected. We start bagging. We look for capnograph. We listen to the chest. And we hold on tight to that tube, that successful airway, because that needs to stay in. And then how do we train for that? We've got the psychomotor training, so the motor skills, and we've got the cognitive training as well. And throughout our induction process, we would step up the intensity of the training. So it would start on a part task trainer, just going through the process. We then do it on a pig carcass. That's how we practice a lot of our halo surgical procedures. We then do it in simulation, and then without giving too much away in our testing process, we have an exam where procedures like that have to be done in a simulated scenario with a number of other things going on that really increase the stress. So stress exposure training or stress inoculation training, so that we know that our teams are capable of doing this procedure in any circumstance. But it doesn't stop there. Again, in our system, we have airway currency training. So every 30 days or 60 days, depending on your clinical level within the service and whether you're full or part-time, we have to go through something called airway currency training, where we revise our airway procedures, including surgical airway. So we just keep it fresh. But on top of that, we expect people to keep themselves psychologically current by rehearsing and simulating in their own brains. And you could do this, while queuing up for coffee. You could be just going through, if I have to do a surgical airway this week, how am I going to do it? Just run through those steps in your mind's eye. Next, please. So you're one step forward in the coffee queue, and then you think, right, I'll do another one. And then, you might have done 4 surgical airways in your head by the time you get your coffee in your hand. And that's really good simulation. That's powerful stuff. We've got such a good, powerful, high fidelity simulator between our ears. It makes sense to use it to prepare for the halo procedures. Yeah, surgical emphysema is going to be one of those anatomical factors that's going to make this a challenging surgical airway. And other ones might be paratracheal hematoma that's distorting the anatomy and ruining your midline orientation. And they can make it extremely challenging. There's good surgical emphysema and bad surgical emphysema. So good surgical emphysema was caused by the injury. There's a laryngotracheal disruption. There's leakage of air into the soft tissues of the neck. And that's something that you're going to save the patient's life from. Bad surgical emphysema is when the patient didn't have surgical emphysema, and then you've tried to do a surgical airway and you've gone in the wrong space and you've connected the bag and you've inflated and you've got no end-tidal CO2 because you've created a false tract, and now you're blowing up the tissues full of air. That's bad surgical emphysema. None of us ever wants to be there. So the good surgical emphysema caused by the injury, you're going to do your best for the patient. And whereas we love palpable anatomy and reassuring landmarks, and we can go straight into the cricothyroid membrane, sometimes the patient's obese, or there's hematoma, or there's a mass of some sort, or there is surgical emphysema, and then you just may need to cut down. You may need to do a vertical incision until you find the airway, and then you make the horizontal incision through the cricothyroid membrane. There's a greater danger of bleeding in that situation. But again, for larger children, teenagers, and adults, where we're going to go through the cricothyroid membrane, this is expected. We're expecting it to be a non-visual, bloody procedure in which we're using tactile senses. We're going to put our finger in the airway and we're going to confirm those tracheal rings. So we're not relying on being able to see the anatomy anyway. It's all about feel. So identifying the midline, cutting down to airway, cutting through the airway and sticking a finger in it, that's the way to go. It does get more complex in infants and small children. But we can talk about that another day if you want.
Indeed. Cliff, could we just look at really some cases from your perspective? Indeed, a challenging case which you've maybe garnered a lot of experience or indeed reflections from regarding FONA. Is there a sort of seminal case in your mind that you sort of really learned a lot from?
There's a few. I've only done 2 in my whole career, so I've been lucky. And I think a lot of that comes down to working in systems that concentrate on first pass success. So not just the salad technique, but the positioning and the adequate dose of rocuronium and all the things you put in place, proper pre-oxygenation, proper hemodynamic resuscitation, all the things you put in place to make that laryngoscopy very likely to be successful on the first attempt. And so in our service, surgical airway is very uncommon, very uncommon. So there's only, despite a couple of decades being there, there's only a handful of cases any of us have come across or aware of. So that's great. There was a case right at the start of our current service where we were still writing SOPs, where a 2-person procedure was taught where the assistant would be holding retractors and the physician would be performing the procedure visually. And it was a guy who smashed his face. He was on a jet ski and smashed into another jet ski, had major facial injuries with hemorrhage and a decreased conscious level. And he was anesthetized, but had an unsuccessful laryngoscopy. And he was temporarily oxygenated with a supraglottic and eye gel while they did a surgical airway. So saturations were sort of maintained in the low 80s. So they had time, and they tried this procedure that was taught back then. And someone had the wherewithal to video it. And I got to see the video. And they didn't have the right tissue planes. They put the bougie paratracheally rather than in the trachea. They thought they were in the airway. They connected. They put the tube over the bougie. They connected the bag. They inflated, but they had no capnography, no chest rise, and they picked up very quickly this is not in the right spot. And so this was a failed surgical airway, which is very rare. And this is something that can really test you psychologically. Where do you go from here? But they had the cognitive capacity to say, right, well, the way we did it's not working. Let's do it a different way. And the physician recut the cricoid membrane and put his finger in and felt those tracheal rings, bougie, tube. So essentially, he essentially for himself invented the scalpel finger bougie technique, even though he'd never heard of it at the time. He realized, he created that approach for himself because he wanted to be sure he was in the airway and it was all very bloody. And that was great. And the fact that they videoed it, the whole team could learn from their, not mistake, learn from their success. And we changed the system. We changed the way we taught it as a result of that case. So that was fantastic for that team to do that. The patient did fine and subsequently gave permission for that video to be used for training. And it's been presented at various conferences by that doctor since then.
No, indeed, and it's informative for many reasons. Like you said, a lot of learning can be garnered from that, and indeed, like you say, the SOPs can be pressure tested and changed on the back of some of these seminal cases. Cliff, could you speak to transitions of care within, so patient handover really of a FONA patient?
Yeah, sure. So maybe if we take it from the point of confirming that end-tidal CO2, the tube's in, we have to be mindful of a few things. If the patient is alive, so it's not a cardiac arrest patient, then they're just like any other intubated patient. They might need ongoing sedation, analgesia, and I would definitely, in our service, give a muscle relaxant. I don't want this tube being coughed out. This tube has to stay in. So the patient's going to be flattened with anesthesia and neuromuscular paralysis for starters. I'm not going to let go of this airway. We'll try and secure it, and we don't have a rigid recommendation about how it's secured. We've got the option of tube ties, sutures, tape, whatever keeps it in, but we're probably going to have a dedicated clinician holding it as well. Because you've gone into the airway much lower down the neck than you normally would, you normally go through the mouth, there is a danger that tube's going to go into one main bronchus. So we're going to be really vigilant about that bilateral chest rise and keeping an eye on the end-tidal CO2 and the saturation. And then at handover, what there's a risk of is that resuscitation team is going to get fixated on this. Many, if not all of that resus team will be seeing a front of neck airway for the first time, and it'll be fascinating to them, and they're not going to hear the rest of your handover, and they'll lose situational awareness. So on the pre-hospital alert, when we call from ambulance to hospital, we'll let them know that the patient has had a cricothyroidotomy, just so when they do their briefing before we arrive, it's not a surprise to anyone. And then on arrival, the person is usually going to be the physician who's holding that tube, is going to keep hold of it during the handover process, the verbal handover, and also during the physical handover onto the receiving hospital stretcher or bed, so that no one else has the opportunity to pull that tube out. And then whoever your airway clinician is that you're handing over to, after the team handover, an additional airway handover to them. What we found at laryngoscopy, why we had to do a surgical airway, and what size tube, how far it's in, how we've secured it, or how we've not secured it, so they're aware that it could be pulled out, and making sure they're absolutely clear on what that is and why it's there and what their challenges might be. If this patient genuinely had an unanticipated, impossible laryngoscopy with a grade 4 view and an inability to pass a bougie, we want them to know that. We want them to know that even with our video laryngoscopy and optimal positioning and paralysis, this patient wasn't intubatable, so that they don't just assume that, oh, these guys failed because it was pre-hospital, let's just pull that out and put a proper one in up the top end, because they're going to end up in the same difficulty. So I think that a really clear handover with closed loop communication, so everyone understands what's there and why it's there, is important. And trying to make sure that the handover, the verbal handover, according to our usual structured template, is done before letting go of the patient, so they're not distracted and they can actually listen. I think those are the important things. In less experienced trainees in other settings, if I see someone running a sim where they expect a surgical airway, I guess some of the common situations in that context would be a delay to doing the inevitable, persisting with other techniques, trying to talk themselves out of it. They can't be wanting me to do a surgical airway. Maybe I need to do something else with the laryngoscope, and trying to talk themselves out of it, trying to wish it away, and that just might reflect confidence as much as competence, and not wanting to fail at a procedure that they may have not had a chance to practice much in the training setting. So I think it's on us as trainers to set our teams up for success. So if I were to put my emergency medicine trainees in the ED through a simulation that required a surgical airway, I would definitely make sure they're already orientated to where that equipment is, how to use it. They've had a chance to practice it on a part-task trainer first before we go anywhere near it in a sim. Otherwise, it's just not fair.
Okay, that's it for this week. We'll be back next Monday with another episode on stroke care and for fast negative strokes and those atypical presentations which can catch practitioners out. And it's a fantastic episode with an author that's published case study and empirical research on non-fast strokes and just articulating and recognizing these types of strokes. Please do rate, review and subscribe to the podcast wherever you get your podcasts, and we'll see you again next Monday. Thanks again.
You're listening to the Pre-Hospital Care podcast on the Medics Academy Network.